Topic for all of us, when to order a CT scan and when to order an MRI. I think most of us have faced this dilemma.
Yes.
When we see a patient, is it to order a CT scan or an MRI? I call upon from DDNPA Dr. Ridwan Khede, Dr. Kailash Godke, Dr. Afroz Gurchan, and the DAS.
Has the privilege of introducing Dr. Deepak Patkar. Deepak Patkar is one of the India's leading consultant radiologists and head of Department of Radiology at Nanavati Hospital, Vileparle. He is globally reputed radiologist with experience of 25 years in UK and India. He is a MD Radiology, DMRD and DMRE trained at Nair Hospital and TN Medical College and Guy's Hospital, London. He is also director of Tele-Diagnosis Service Private Limited, dealing in teleradiology with clients in US, Africa and Middle Asia. He has developed approximately more than 500 lectures and oration at national and international level. He also has more than 75 international publications predominantly on neuro and musculoskeletal MRI related topics, one of the best being central nervous system tuberculosis. He is a postgraduate teacher for DNP in radiology at national boards from 2002 till date and a postgraduate diploma teacher for CPS from 2003 till date. He had a mastery, commitment, patience and strong sense of giving back and to reach to students of various fields other than radiology like biomedical and IIT students. He has successfully organized many national as well as international conferences. With this, I call upon Dr. Deepak Patkar for presentation.
What are the advantages and advances in CT and MR technology? And what are the current clinical applications in terms of CT and MR, and when we should choose CT over MR and MR over CT? Before I do that, I must acknowledge contribution to this talk from my colleague from THANE, Akshay Diagnostic Center, Girish, colleagues in the department, Amit, Mitush and Parul for the presentation, and the presentation is designed by my colleague in the department again, Dipali. I'm talking on behalf of Akshay Diagnostic Center, which we have currently set up about 3 months back near Navneet Motors, Gokul Nagar. We have 16-slice CT scanner, state-of-the-art G evolution ultrasound and color Doppler machine, 300 mA X-ray with digital radiography system, and well-trained staff, which is governed by Dr. Girish Evankar. What we'll do in the next 20-25 minutes is look at how radiology has evolved over the last 50 years or so, understanding how multi-slice CT and current MRIs work, what are their current indications, what are the advantages over each other, and what are the recent advances in CT technology before we conclude. You'll be surprised to know that X-rays were discovered as early as 1895. Roentgen was the one who did this, and for almost 75 years we used to use X-rays to do X-ray of chest, limbs and certain procedures like bariums, IVPs, myelography, etc. Till 1971, that year really revolutionized the way we image patients. In 1971, EMI company in UK developed a CT scanner which used to take about 45 minutes for head scan and had resolution of 16 by 16 pixels. Today we talk about multi-slice technology, which covers whole body within less than 18 seconds. So reconstruction times of 45 minutes have now gone to milliseconds, and within matter of 5 seconds we can actually do a coronary CT scan. By adding functional imaging like molecular CT or functional MRI, we can actually understand not only the pathological anatomy of the organs, but also the functional aspects of tumor characterization, how they behave, how they respond to chemotherapy or radiotherapy. So from just a structural imaging like taking hand X-ray or chest X-ray or limb X-ray, or doing myelography, bariums, which were relatively invasive procedures, 2 CT scans in 1971 and MR in 1982, which took hours to get scans done and reconstructions done. We talk about milliseconds and seconds and cover whole body in less than 18 to 19 seconds. And also from structural imaging, we have moved to functional imaging to understand the biology of tumors, biology of infections very well. Now, how is current CT and MR different from CTs and MRs of 70s and 80s? What we had in the beginning in 1970s was a CT scan which would rotate over 5 or 10 seconds and then move down by 1 centimeter. We now have CT scans which continuously rotate, and one rotation takes less than half a second. And in that half second, we can get as many as 64 slices. So in a rotation of 1 second, we can get as many as 128 slices. And now we have CT scanners which scan up to 512 or 1000 slices per second. Because of that, the radiation to the patient has reduced by 1/64 times. Also, we can get slices which were 1 centimeter to now 0.5 centimeters. We can get resolution which is much superior because of faster scanning capability. Patients don't have to hold breath. So serious patients can be scanned without telling them to have to hold the breath. So within a matter of few seconds, we get images which are very high resolution, which can give you images in single rotation up to 64 to 128. You get what is called as isotropic volumetric data. That means whatever you acquire in transverse plane can be reconstructed into coronal, sagittal or any oblique plane that the surgeon wants before he operates with same kind of resolution, which is much superior to what was available about 30-40 years back. Because the data is volumetric, reconstruction is much superior. We can look at each organ separately. We can take out bones from the body. We can take out liver from the body. We can measure brain volumes, hippocampal volumes by extracting data from the entire body set. Also, post-processing in different planes and color coding the data, the algorithms that are available today can give you very specific information of the body part that you are interested in. It also allows us to understand the complex anatomy and diseases much better. What is happening about 20-25 years back was all of us were trained to look at body as we operated the patient or as we dissected the patients, dead patients in anatomy museum. Now we can look at planes whichever the surgeon wants in a matter of few seconds, and the slices that we obtain are less than 1 millimeter. So better understanding of complex anatomy. The classic example is temporal bone anatomy. Better understanding of the diseases like gliomas in the brain, hepatocellular carcinomas in liver, or complex malignancies in the abdomen can be understood much better. Also, it allows newer clinical possibilities. The way we treat patients by chemotherapy or radiotherapy, their response can be judged in a much superior fashion. Also, the uncompromising image quality takes us to a newer level which we had never seen before or could never imagine few years back. So we look at different indications today which are available for multi-slice CT scanners and their relationship with MR, what is advantageous over the other. So we look at head imaging, neck imaging, chest, abdomen imaging, pelvic imaging, musculoskeletal trauma and infections, and then look at CT angiography, how it has changed the way we look at vessels without having to catheterize the patient. So we'll start off with head indications. What are the current indications for CT scan in head? It is the best investigation available today for looking at patients with head injury, acute or hyperactive strokes which can be thrombolized. If the patient is shunted for hydrocephalus, to assess the shunt functioning. Patient with transient ischemic attack can be assessed using MRI. Follow-up of a known tumor who is being treated with chemo or radiotherapy can be assessed using CT and MR together. And CT, HRCT as it's called, high resolution CT scan for temporal bones, for patients who require cochlear implants or patients who have got ear infections. You can see complex fractures following head injury very accurately using CT scan. You can look at subdural or extradural hematomas very well. If there are any cerebral contusions which are causing midline shift, can be assessed very accurately using CT scan. If patient has acceleration, deceleration injury which gives rise to axonal injuries without any subdural or extradural hematoma, they can be better assessed using MRI. So if you have cerebral damage without subdural or extradural hematoma, what we do is what is called as a gradient imaging, which allows us to look at microhemorrhages in the brain, which gives rise to coma to the patient. In hyperactive stroke patient presenting with focal neurological deficit, you need to differentiate hematoma from acute infarct. Hematoma is better seen on CT scan than on MRI. Acute ischemic stroke, if the patient is not going for thrombolytic therapy, can be detected accurately using CT scan. So, infarct looks dark on CT scan, hematoma looks bright on CT scan. If patient comes to the hospital within few hours of getting stroke, combination of routine MRI imaging with diffusion imaging is superior. Using diffusion imaging, MR can pick up infarcts as early as within 15 minutes theoretically and definitely within 1 hour on all the occasions. So if the patient has to be thrombolized, MR with MR angio is the superior investigation compared to CT scan. If you are looking at CNS infections like cysticercosis or tuberculomas, MR is superior, but CT scan show ring enhancing lesions in tuberculomas or calcification in cysticercosis quite accurately. Intracranial masses, patient would present with focal neurological deficit or convulsions or headache, and many times CT is the first investigation. It can detect malignant tumors like glioblastomas, or it can detect benign tumors like meningiomas very accurately. But if you are looking at characterizing the tumors better, trying to understand their behavior better, MR is a superior investigation. Other advantage of MR is something like pituitary microadenoma, which are tumors of pituitary gland which are lesser than 1 centimeter in size. This is a 5 millimeter size microadenoma, or a very small tumor like acoustic neuroma can be missed on CT scan, and MR then is superior. So choosing right investigation is very important in right situations. So understanding the patient's history and what is the right investigation for the given situation is very, very important to cut down the cost to the patient. Temporal bone can be accurately assessed using high resolution CT scan. So if you are looking at the complex anatomy of temporal bone, which is virtually not possible using X-ray say 30 years back, we should do Schuller's view or oblique views to look at internal auditory canal, they are no more required. So very, very tiny middle ear structures or internal ear structures like semicircular canals, cochlea, vestibule, the seventh adenal complex can be demonstrated today using combination of CT scan and MR. If the patient is going for cochlear implant, it is important to understand the labyrinthine and cochlear pathology very well. So very, very tiny lesions like labyrinthine aplasia, common cavity which is a congenital malformation, cochlear hypoplasia, these kind of patients cannot undergo cochlear implant. That can be detected. Once the patient is fit for cochlear implant, we need to measure the cochlear turns where the electrodes can be placed, and that can be done by using combination of CT and MR. Complex fractures of temporal bones like this transverse fracture here, a longeval fracture here, or a combined fracture, transverse as well as longeval here, can be detected using high resolution CT scan of temporal bone. In the neck, majority of the tumors like CA larynx here or supraglottic carcinoma can be detected accurately on CT. What we are looking for is staging the tumor, whether the cartilages are gone, lymphadenopathy is there or no, vascular anatomy is encased or no, can be accurately assessed using a multi-slice CT. Benign tumors like this laryngoscene also can be assessed using CT. MR has relatively limited